Yes, ma'am, we are live now.
Hello.
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
Can we also have the ESI anthem?
Pray.
ESI prayer.
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday.
Over to you, Harshina.
Okay. Can I have Anubedita ma'am's CV? I would want to introduce Dr. Nivedita Arunachala ma'am, who's going to be today's chair. Uh,
Sorry to interrupt, Harshini ma'am, but I think there is some lag. Your voice is
Heaven
not
Maternity
audible.
and Fertility Clinic, international peer-reviewed journals. She's an active
Now,
member of Foxy Governance Initiative. It's not audible now also? Secretary, conference coordinator, panelist,
now okay, ma'am.
and Nexus Public Awareness Committee member at present at OXY 2026. Areas of specialization are high risk obstetrics, gynec endoscopy, reproductive medicine, minimally invasive surgery. Over to you, ma'am. And can we have the speaker's CV also? Rituka ma'am,
Yes.
CV. Ramni ma'am has some. Ma'am
Yeah,
is here.
I am.
Okay. I would also want
Yeah,
to
yeah.
introduce Ramni
You
ma'am.
don't, no need, no need.
No
You go ahead with
introduction for
yeah.
endometriosis. So, Nivedita ma'am, do you want to introduce Ritu Khanna ma'am?
Yes, yes, sure, Dr. Ashni. So before that, I'd like to say it's actually indeed a privilege and a pleasure to chat this session alongside the one and only inspirational Professor Dr. Ramani ma'am. So thank you to the society as well for inviting me as a chairperson. So going on to introduction of Dr. Ritu Khanna ma'am. Madam is the director of Khanna Medical Center Fertility Clinic of Varanasi, the fertility specialist and endoscopic surgeon. Madam's organizational position she was a national vice president, Indian Fertility Society 26 to 28. She is the secretary Society of Fetal Medicine up chapter 26 to 28, ICOG governing council member of 26 to 28, a central executive member Society of Fetal Medicine 24 to 26. Madam was a chairperson FOXI Food and Drug Medico Surgical Equipment Committee of 21 to 24. Madam is a vice president of Varanasi OB-GYN Society of 26 to 27, executive member of UPCOG. Is working on exclusive single embryo transfer. And Madam was awarded Dr. B.C. Roy Memorial Award of 2018 for outstanding contribution in the field of gynecology. And also she was awarded the Presidential Award of 2021 by IMA Banaras for exemplary good work and service in the field of gynecology. She has published many papers on male and female infertility, published the first Indian study on the role of CoQ in male infertility. She has presented many papers in ISAR, IFS, and AICOG. And also, she is a peer reviewer for JOFM and Fertility Science and Research. Over to you, madam.
Yeah, so thank you so much, Niveda. And at the outset, my deep gratitude to the president of ESI, Dr. P.D. Mahapatra sir, and the Secretary General of ESI, Dr. Pradeep Kumar Mitra, the president, TNFOG, Dr. Vidya Prabhakar, and Secretary TNFOG, Dr. Sampat Kumari ma'am. And also my special thanks to Ramani madam for giving me this opportunity to be here and inviting me for this exclusive webinar series by ESI and TN Tamil Nadu Obstetric Gynec Society. So thank you, madam, for giving me this opportunity. And I would come now directly to my topic on the medical management of endometriosis. Coming to the medical management of endometriosis, we know endometriosis is a chronic inflammatory progressive gynecological condition. It's characterized by the presence of endometrial glands and the stoma outside the uterine cavity. Whenever the endometrium is healthy, there's a good coordination between the progesterone estrogen signaling. But when this progesterone estrogen signaling gets disrupted, it results into a progesterone resistance and an estrogen dominance over here, and that leads to the disturbance and leading to endometriosis. And this is heightened by the inflammation, and we increase the pelvic pain and decrease the endometrial receptivity to the embryo implantation also. We've got so many symptoms that we're all aware of, and we know that it's a benign, yet it is invasive. It has got a high post-therapy recurrence rate and no cure or eradication in sight, chronic disease therapy all throughout the menstrual life, and an inflammatory disorder. So it also affects the adolescent and young female. It causes infertility, it increases the chances of surgery, and also increases the chances of hysterectomy. If we look at the prevalence, 20 to 40% of infertile women and 5% of fertile women are suffering from endometriosis, 6 to 43 patients of women who undergo laparoscopic sterilization, and 52% of teenagers. The global study of women's health said 64% women affected with endometriosis are in the prime age. It affects the sexual life, the family relationship, of course, affects job, school, everything, and she feels that she's really out of the world. Lot of delay from the patient's side, unaware of this, and treating irregularities as normal, and also the doctor from the medical profession, resistance to referral or misdiagnosis or maybe missing things leads to the trouble. So 7 years of gap, which comes, from to the diagnosis when we reach up to it. So ASRM stated that endometriosis should be viewed as a chronic disease that requires a lifelong management plan with a goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. RCOG and SOGC guidelines have recommended empirical treatment as a best practice for treatment of endometriosis. Now, when do we require the medical treatment here? So medical treatment could be required as a first line treatment after surgery to reduce the recurrence, or when the surgery is not possible or is refused by the patient. The treatment aims at what do we really want? Are we going to treat the disease or the symptoms? And why are we treating? Do we want to improve the natural fertility, increase the chances of success at ART, or pain relief as an alternative to the surgery, pain relief while you're waiting for a surgery, or as an adjunct to the surgery, as prophylaxis against the disease occurrence or a symptom recurrence? So it decides what your aim is going to be, and that's how you take it forward to the management. Now, the manipulation of the endogenous hormonal milieu is the basis for the medical management of endometriosis. The estrogen is known to stimulate the growth of endometriosis, and the hormonal therapy has been designed to suppress the estrogen synthesis and thereby inducing atrophy of the ectopic endometrial implants or interrupting the cycle of stimulation and bleeding. Now, the implants of endometriotic react to the gonadal steroid hormones in a manner which is similar but not identical to the normally stimulated ectopic endometrium. Now, withdrawal of the estrogen stimulation is going to lead to a cellular inactivation and degeneration of these implants, but really not going to make them disappear. So we have medical treatments that combine oral contraceptives and the oral progestins as the first line. And then we had the danazol, which we did not like to use, and the GnRH agonist. And now we have the GnRH antagonist. Now, the treatment of endometriosis with the combined estrogen progesterone was used to induce the pseudo-pregnancy, resulting amenorrhea due to desensitization of the endometrial tissue, and the modern equivalent is the continuous use of these OCPs. Any low-dose combination containing 30 to 35 milligrams of ethinyl estradiol used continuously can be effective in the management of endometriosis, and a symptomatic relief of dysmenorrhea and the pelvic pain is reported in 60 to 95% of the patients. Following first year, the recurrence could be around 17 to 18% and 5 to 10% of an annual recurrence rate. Now, when a combined OCPs are given cyclically, the use may provide a prophylaxis against either the development or a recurrence of endometriosis. And now, if you reduce menstrual bleeding occurs in women taking OCPs, may be beneficial to the women who are having a prolonged and a frequent menstrual bleed, which was known to be a risk factor for endometriosis also. But yes, it's safe and well tolerated and good for the dysmenorrhea, but it would work in patients who would not desire fertility. Danazol, because of a systemic exposure, high risk of masculinizing, was withdrawn later. And GnRH agonist used for a very short time because of the risk of osteopenia and could not be used for more than 6 months. Then came the progestins, which exert an anti-proliferative effect by causing an initial decellularization of the endometrial tissue, and that's followed by an atrophy. This can be considered as a first choice because they are as effective in reducing the AFS scores and pain as danazol or as the GnRH analogs were, and they have a lower cost and a lower incidence of side effects. If you look into the progestins, we had C21 progestins, medroxyprogesterone, cyproterone, C19 not testosterone, estrins and gonadins. Estrins were norethestone acetate and dinogest. Gonadins were the norgestrel, levonorgestrel, desogestrel, and gestodine. Spironolactone was drospirenone. Now, progestins were regarded as very, very effective treatment. But what happened was they had to be given at high doses, and therefore there was a likelihood of the adverse effects and elevating the risk of cardiovascular adverse events. So we really needed a low-dose progesterone, working very, very efficiently and not causing the side effects. So there came this molecule as Dynogest. There was an additional double bond and cyanomethyl instead of an ethynyl group in a 17 alpha position. So the special chemical structure gave it a very, very unique pharmacological profile. It combined the properties of 9 not testosterone derivatives and the progesterone derivatives. This could be used continuously, and it was evaluated in more than 1,000 women for a safety, tolerability, and efficacy being recommended by ASHRAE, RCOG, and SOGC. When we look at this and look at side effects, we find that there was, if you look at the blue line below, that is the Dynogest, and the pink one is a Leupride. So Dynogest has very minimal incidences of hot flushes and even minimal weight gain here. Now, further, if we look to the estradiol, we know that the hot flushes are because of the low levels of the estrogen. And Dynogest, when it was used over here for 12 weeks, 24 weeks, 52 weeks, the estrogen level remained in the window that we wanted from 30 to 50 micrograms. And leupride acetate, if you look from the baseline to 24 weeks, it went drastically down as compared to Dynogest. And the estrogen level, now this is the therapeutic window, and to avoid the hypoestrogen effect, the hot flushes, we need it to be in a level of 30 to 60 picogram, which was maintained by Dynogest in spite of it being used for a very long time. The bleeding pattern became irregular after initiation of the Dynogest, but if you look, it settled down in some time, and the frequency intensity of bleeding decreased with the continued treatment. So when this treatment continued for a period of 1 to 3 months, the amenorrhea increased and the infrequent irregular bleeding went down. So we had also cetrorelix as an agonist, but that was injectable. And now we've come up with the oral non-peptide GnRH antagonist, which suddenly shuts down the release of the LH-FSH, and it is very, very rapidly reversible also. So a GnRH antagonist, unlike the agonist, does not cause an initial surge in the LH and FSH, suppresses ovarian hormones immediately rather than taking 7 to 14 days, and degree of ovarian suppression is dose dependent. So an oral medication is much, much better, and there was significant improvement compared to the baseline in majority of the patients. They said, let's compare this antagonist to a Dynogest 2 milligram tablet, and when it was seen that elagolix 150 milligram given and compared with Dynogest 2 milligrams as regards the VAS score, from the baseline to day 85 to day 169, both the treatments were found to be well tolerated, and it was as efficacious as Dynogest. Now, after we used elagolix, there was a significant reduction in the BMD at the spine after 12 weeks and at the spine and the femur after 24 weeks. Long-term elagolix had anticipated changes because of the decrease of the estradiol level. So there were hot flushes, reduced bone mineral density, and increased lipid levels. The incidence over 12 months shoot up to 30 to 55%. When we compare Dynogest with elagolix, Dynogest is effective and elagolix also seems to be effective, but elagolix can be used for a shorter time, up to 6 months, and Dynogest could be used for a very long time. And there could be some menstrual irregularities, but they vanish with the time, and BMD could be a concern with elagolix. ASHRAE 2022 said it's recommended to offer women hormone treatment, combined hormonal contraceptives, progestogens, agonist, GnRH antagonist as one of the options to reduce endometriosis-associated pain as a strong recommendation. It's recommended to prescribe a combined hormonal contraceptive to reduce endometriosis-associated dyspareunia, dysmenorrhea, and non-menstrual pain as a strong recommendation. It can be considered to prescribe GnRH antagonists to reduce endometriosis-associated pain, although evidence is limited regarding dosage or duration, and the GDG recommends antagonist as prescribed as a second-line treatment. RCOG said it's inconclusive evidence if NICDs are effective in managing endometriosis-associated pain. Suppression of ovarian function for 6 months will reduce this pain. COCs, MPA, danazol agonists are equally effective, but their adverse effects and the cost profiles need to differ and should be considered as and when. ACOG recommended 3 months trial of NSAIDs and a cyclic OCP. If this pain still persists, then do a laparoscopy. If the patient is more than 18 years, she wishes to avoid surgery, give her empiric GnRH agonist. If the pain resolved, then diagnosis of endometriosis is confirmed. Any low-dose OCP, 30 to 35 microgram, used continuously to achieve amenorrhea, can be effective in treating endometriosis, and the cyclic OCP could also provide prophylaxis against development or any recurrent of endometriosis. Then came the combinations with Dynagest and the ethinyl estradiol. So the continuous Dynagest versus cyclic estradiol in management of pelvic endometriosis, divided into 2 groups at 3 and 6 months, endometriosis-associated pelvic pain significantly decreased in patients requiring Dynagest ethinyl estradiol compared to patients receiving Dynagest alone. And the cyclic control was higher in the Dynagest estradiol group, and the quality of life was found to be better when given. There was a comparison of Dynagest and Dynagest with ethinyl estradiol and another with estradiol valeriate for looking at the pain. Now, when these 3 groups were divided at Dynagest, ethinyl estradiol, and ethinyl valeriate, it was looked into the VAS scores of pelvic pain, the CA125, and the AMH levels and the size of endometrioma. There was no statistically significant difference between pre and the post-medication CA125 AMH VAS scores and cyst in all groups, and statistically significant decreases were seen in the cyst size, and the VAS scores indicated response to therapy in all the groups. The use of combined oral contraceptive for treatment of endometriosis. This was a systemic review of evidence with 9 RCTs and 9 observation studies meeting the inclusion criteria, and a continuous administration seemed to be much more useful than a cyclical administration, and the available literature says it's effective for the relief of endometriosis-related dysmenorrhea, the pelvic pain, and the dyspareunia. Now we have the COCs versus the elagolics. We know that elagolics will cause a sudden shutdown of the LH-FSH, and the Dynagest ethinyl estradiol decreases the GnRH pulsatility, the FSH-LH, the follicular development, and it's a progesterone receptor agonist, decreasing endometrial proliferation and inflammation. The network meta-analysis, Call et al. In 2024, treated the 3 arms, elagolic, Dynagest, and combined COCs, GnRH analogs, and others versus the placebo, and said Dynagest and elagolics are effective for pain relief, but Dynagest ranking higher at 3 months and maintaining efficacy at 6 months. There was a safety-focused meta-analysis in 2024 that said Dynagest has a milder side effect profile than elagolics, supporting that it can be used for a long-term therapy. And there was a network meta-analysis, Leque et al. In 2025, and both the drugs, they said, they had leuprolide with OCP, Dynagest, elagolics was significantly more effective than placebo for pelvic pain. Elagolics excelled in the dysmenorrhea and dyspareunia, and Dynagest showed consistent pain relief across symptoms and had got less of adverse effects as compared to elagolics. So if we compare ethinyl estradiol Dynagest with elagolics, it's effective ethinyl estradiol Dynagest for dysmenorrhea, moderate improvement in dyspareunia, and elagolics has got a dose-dependent reduction in dysmenorrhea. Sustained reduction in dysmenorrhea and non-menstrual pain over 24 months with Dynagest, but maintains pain relief, non-menstrual pain and dysmenorrhea for 12 months, but efficacy beyond this is yet to be studied. So Dynagest could be approved for as long as 2 years, and elagolics 150 milligram OD for 24 months and 200 milligram BD should be limited to 6 months. With ethinyl estradiol Dynagest, there's no significant bone mineral density loss even after 24 months of use, but dose-dependent bone mineral reduction seen with 200 milligram twice daily, and after around 12 months, lumbar and hip bone density decreased by 2 to 3% over here. So ethinyl estradiol damages for a long-term management, bone safety tolerability, whereas elagolix reserved for severe refractory cases, but requires a very stringent monitoring looking into the bone density and the mental health. So there came a solution to this was antagonist with the add-back therapy. So we had rilugolix 40 milligram, estradiol 1 milligram, and norethindrone acetate 0.5 milligram. So this came as a GnRH antagonist in combination with an add-back therapy. Rilagolix selectively binds to the pituitary GnRH receptors and it decreases LH, testosterone, estrogen, and therefore the pain is taken care of and also the heavy menstrual bleeding. So there is a dose-dependent reduction in dysmenorrhea and rilagolix shown to provide comparable effectiveness to a leuprorelin in lowering the pictorial blood loss assessment chart scores and a greater proportion attaining these levels below 10 during the treatment. Estradiol was added and it interacted with the nuclear estrogen receptors in the estrogen responsive tissues. And this helped to prevent the bone density reduction and associated estrogen deficiency, which was occurring because of rilugolix. So it promoted the proliferation and growth of the endometrium at a very high concentration and not at this concentration which it has been added. Progestins netta acted by binding to the nuclear receptors that are expressed in the progesterone responsive tissues. So here it's going to protect the uterus from the adverse endometrial effects of the unopposed estrogen. And if you look at the estrogen threshold, 10 to 20, there'll be a lot of shrinking but bone mineral loss. 20 to 50, there'll be a decrease mitigating while it's going to mitigate the hypoestrogen effects. And more than 60, it'll cause growth. So that is why this dose was selected so that it caters to the bone mineral density and maintains the estrogen levels at the time, not leading to a hypoestrogenic effects. So you exclude pregnancy and discontinue all your hormonal contraceptive. Start this rilugolix with add-back 1 tablet once daily at the same time with or without food. Start as early as possible after the onset of menses and no later than 7 days after the menstruation. So total duration for around 24 months. If you miss, you start as soon and continue the regular dosing as you do. Now, rilugolix maintains a mean estradiol consistently between 36.8 and 39.1 picograms. So all individuals' progesterone were checked and they remained below 1.57 nanograms per ml. Rilugolix, when you start, it reaches a steady state concentration by day 12, while estradiol, hemihydrate, and netta achieved this with 14 days. So mean absolute bioavailability of 12%. Now, when they looked at the terminal phase elimination half-life of rilugolix, it was average of 13.2, of the estradiol was 7.7, of the norethindrone was 3.1 hours, and therefore scheduled as a OD dosing. But to be avoided in any history of deep bone thrombosis, vascular disease, thrombogenic valvular diseases, inherited acquired hyperglobulopathies, coagulopathies, and uncontrolled hypertension, headache with focal neurological symptoms of migraine headaches, those who are pregnant, those who have known osteoporosis, current history of breast cancer, hormone-sensitive malignancies, and hepatic impairment of disease, undiagnosed of abnormal uterine bleeding, and any anaphylactic reactions. Adverse effects, but just as we have as headache, vasomotor, could occur to some women, which we need to be aware of. So it's been regulatory have approved it. The US FDA, EMA, MHRA, CDSCO, and also TJ Australia have approved and also been recorded by NICE, SOGC, and ACOG as this. So clinical evidences that we have or trials are the SPIRIT 1 and the SPIRIT 2 in endometriosis associated pain, and 2 replicate phase 3 multicentric randomized double-blind placebo-controlled trials were done and evaluated the combination of rilugolix, estradiol, norethindrone compared with placebo in women with a substantial endometriosis-associated pain. Now, to evaluate the delayed rilugolix combination therapy, they put it into 2 groups. One SPIRIT 1 had 638 participants and SPIRIT 2 623, 212 rilugolix combination therapy right from the beginning, and delayed rilugolix combination means that they were put on rilugolix combination for 12 weeks, followed by relagolics, the delayed relagolics alone for 12 weeks, 40 milligram, followed by relagolics combination for another 12 weeks. If we look into the graph with dysamenorrhea, we find that the pink and the blue columns almost stand parallel. And of course, the ones who had relagolics combination started right from the beginning responded better to dysmenorrhea and also to the non-menstrual pelvic pain. And it would look at the therapy. How fast does it work? It was observed that this pain relief started as early as 4 weeks. There was the greatest maximum relief in dysmenorrhea by around 8 weeks, and the greatest relief of pelvic bone between the menstrual periods was achieved by around 12 weeks. If you look into the adverse effects, when the relagolics combination therapy was started right from the beginning, we look at the gray, it was less of bone mineral density decrease rather than the pink when we had a delayed relagolics combination therapy. The same went with hot flushes, which were less when you started relagolics combination right from the beginning for these patients. So, reduced endometriosis associated pain from the moderate, severe to minimum levels. It improved pain associated functionality and minimized the hypoestrogenic effects of this. So, when you compare your relagolics combination with allagolics, the efficacy in reducing pain was better than the side effects. It had a good GI tolerability, and also the side effect of hypoestrogenism and the bone mineral density was less. And when this relagolics combination compared with leuprolide, leuprolide had a flare effect. This did not. And also, there was it was more effective, and relagolics more than 70% achieved significant reduction, and it has preserved the side effects due to its add-back therapy with it. So therefore, in suspected endometriosis, diagnostic steps become laparoscopy and imaging can be combined with the empirical treatment of hormonal contraceptives and progestins, and it is recommended to offer hormone treatment as one of the options to reduce the endometriosis-associated pain. After laparoscopic excision or ablation, you can consider hormonal therapy to prolong your benefits of surgery and manage the symptoms. The Foxy EEBR 2025 said, first line oral options, COCs, or progestins. So these combined oral contraceptives, usually continuous for 3 to 6 months, would reduce this dysmenorrhea, and the non-menstrual pain and could be a cheaper option. And the second line stands as antagonist to be offered along with GnRH. A combined hormonal add-back therapy could be used. So relagolics combination was a definite novel hormone therapy for symptomatic management, and unlike the GnRH antagonist, the hypoestrogen side effects were minimal. The tolerance was much better and can be used for a longer time. So there's so many poor choices you have, but too many choices will really steal away your peace. So for your patients, individualize your treatment and find who is the best friend and take it as the best choice. So thank you so much for a very patient hearing.
Thank you so much, ma'am. It was such a comprehensive, detailed medical management. Thanks a lot, ma'am. Over to Nivedita, ma'am, for her inputs. And Ramani, ma'am.
Yes, ma'am. Thank you, Dr. Ritu Khanna, for such a comprehensive presentation, ma'am. As you said, the important takeaway is that the medical management should be individualized according to their predominant symptom, their contraindications, their adverse effect profile, and the patient preference. Thank you so much, ma'am. Thank you for that.
Ma'am, I would also want to highlight that the pharmacology behind, the molecular structure of Dynagist, how you had explained it, and estrogen, the threshold hypothesis, everything was very nice. And particularly a personal thing I would want to say, like, it was hearing an educational podcast. Your voice was so mesmerizing that, I was like listening to every single word of whatever he was saying. It was so nice, ma'am. Thank you so much.
Thank you. Thank you so much. Thank you.
Over to Pallavi. Can you share Jyoti ma'am's CV? Nivedita ma'am, just
yes, ma'am. So I welcome Dr. Jyoti Mishra, ma'am, who is going to take us through the surgical management of endometriosis. Madam is the director and HOD and advanced laparoscopy and robotic surgeon of Yatharth Hospital, Noida, MIS training done in Kiel, Germany. She's a member of ICOG, treasurer of UPIAGE, director of Excel Academy of Laparoscopic Training, also a FOXY endoscopy training, and an ex-co-convener of FOXY AUB committee, ex-North Zone coordinator of FOXY, endometriosis committee member, and also an ex-member of Noida Obs and Gyne Society. Over to you, ma'am.
Thank you very much. The last thing, executive member, not ex-member. I'm currently in Noida Society. Yeah.
Okay, ma'am.
Thank you, Dr. Ramani Devi and all the team for inviting me here. I'll start sharing my slides. I'm sending my request to share my slides.
Pallavi, you've stopped sharing your slide, right?
Yeah, I've already stopped, madam.
All right. So please.
Is my PowerPoint visible?
Yes, ma'am. I think the screen is visible. I think you'll have to go to the.
Stop share and then reshare. It's visible now? My PowerPoint?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Go to slide
Hello,
share.
Dr. Jyoti. Good evening.
Hello, Dr. Ramani, ma'am. How are you?
Welcome.
Yeah. It's a
Yeah.
pleasure to be on this platform and thank you all for
Yeah,
inviting me
yeah.
here. So I'll start my presentation. Let's take this on. Okay. So my topic is surgical management of endometriosis. This side. Fine. Endometriosis has been, as Dr. Ritu has already introduced, it is seen in 10% of women in infertility age 2, but 30% of all infertile women. If we look back at the history, these women were often put in prison and it was thought that they were drug addicts and behaving like that. But it is the problem which normally by the time it gets diagnosed, takes about 8 years for the problem to be confirmed that it is endometriosis. This is the history of Dr. Rokitinsky, how he identified this in 1860. Definition, we all know it is endometrial tissue placed elsewhere. So we can say ectopic endometrial tissue, which is outside the uterus. There are various sites of endometriosis, not only pelvic, but also extra pelvic, and there are various presentations. We'll see them all in our videos. So many classifications have come. So it all proves that it's a very complex disease. Still, there's no confirmed treatment for it, nor any grading system for it. We all have to counsel our patient and understand that it is a progressive disease. It's a recurrent disease. There's a rare possibility of malignancy, and silently it can invade nearby organs. Our treatment should aim at symptom relief to excise or destroy all visible disease, restore normal anatomy, near normal anatomy, conserve ovarian function, avoid damage to nearby vital organs, and to prevent or delay recurrence. So surgical choices, we have medical, surgical, and alternative therapies. Laparoscopy robotic will not discuss the benefits, but there are obviously limitations of laparoscopy. So we have robotic surgery now. If you compare the two, I'll quickly take you through the videos. This is a talking happening. So robotic surgery differs from laparoscopic surgery that you have a 3D vision. That's most important. And then the instruments, there are so much range of movements of these instruments. They're not straight stick instruments unlike laparoscopy. And the surgeon can go and sit. Endometriosis surgeries are long surgeries. And you have to do very fine and meticulous dissection. And that's the robot coming in and which is being docked. So once the robotic arms are docked, the trocars don't keep on moving in and out. That's why the patient has least post-operative pain at the trocar sites also. And that the robot is docked. So normally wisdom comes as you age, and with robotic surgery, as we age, we learn more and more techniques. We are more and more bold in our decisions. But robotic has made it easier to perform for senior surgeons, like who have not got a lot of workload as we age. Plus 3D vision, the eyesight doesn't come in the way, the tremors are filtered. So it's really beneficial to do. Especially, I would justify that robotic is really justified in doing endometriosis surgery, especially when it is deep endometriosis. These are the benefits of robotic, the magnification. That's a firefly mode where you can see the ureters nicely. We'll see videos of that. So points to consider are consent is very important, full counseling, and even the small possibility of oophorectomy should be taken because you don't know what's going to be inside. Proper bowel preparation, selecting correct instruments, and planning your port placement is important. Should we drain the cyst? Should we coagulate the walls? Should we do cystectomy? Most of the time when you do cystectomy, it works well and the recurrence rate is lower. What should be the power setting? Suturing the edges should be done or not? So let's see I'll quickly go to video sharing. So I'll stop sharing this and I'll share my video, which is with the narration and one second. Just opening. So this particular video is all about endometriomas, variety of endometriomas and how we work on it. Is my video visible?
No.
Okay, I'll stop share and I'll reshare. I think it's visible now.
No,
Is it
it's
visible
not.
now?
Not it's not. Yes.
So this was a presentation I had given somewhere. Can you hear also the narration?
Yes, yes.
Just stop. Is my audio and narration visible and heard?
It's not audible, ma'am. It is visible. The video is visible, but the narration is not audible, ma'am.
Okay, so I'll keep giving the narration. So there are various surgical indications as the video keeps going. Let's see. These are the risks of structure, torsion, risk of malignancy, effect on other organs. So while you're planning surgery, you should be prepared with everything. Effect of ovarian reserve is something which we are all concerned about. So we should use minimal cautery and be in the correct planes to prevent injury to the ovarian tissue. It's a progressive recurrent disease which has to be repeatedly superimposed to the patient and told that it can recur. The problem which we may come across later, so right patient selection and right surgeon selection. Somebody who does good number of surgeries where you have a lot of multi-specialty departments, there should be the place where the surgery should be done. First surgery should be the complete surgery. Let us begin with small endometriomas. See, this is looking like a very clean pelvis, but if you lift the moment you lift the ovary, you find the small endometrioma will give way and fluid will leak and you will know where to excise it. Very small endometriomas, less than 3 centimeters, can just be drained and the walls coagulated. You need not try to find a plane of cleavage and the cyst wall in very small 3 centimeter or lesser endometriomas. This is a larger endometrioma. First step is adhesive lysis to make the endometrioma free. Mostly by the time you lift it up, it drains. And to find the cleavage plane, you need not use these advanced instruments like ultrasonic and ligature because they tend to seal the edges. Here you need to cut it with a scissor or strip off the walls. You need to tear it apart. And with magnification of laparoscope, you can go closer and see the cyst wall and differentiate it. Usually it is chocolate stained, also colored with a chocolate color. So you can make out where the wall is. Don't pull out with the trocar. You can pull it out through the trocar or put it in a bag. An interseat can be placed, especially when it is posterior wall adhesions, to prevent recurrence of bowel adhesions later on. So we all know that endometriosis is a hyperestrogenic state. So it's not just endometrioma. You may find a family of things like fibroids, endometriomas, and adenomyomas. This patient had endometrioma. She had an adenomyoma as well as a fibroid, which were all dealt with. It could be bilateral endometriomas. Here again, the ovarian function you have to conserve in young women. So sometimes I use vasopressin, sometimes I use hydrodissection to finally limit the degree of damage and to remain in the correct plane of dissection. So once it's like walking on a rope. Large endometriomas, you don't leave it. You just keep walking on a rope like one instrument after the other. Use current at the minimum power setting. Stay away from the hilum. Only point coagulation. You can use little spurts of irrigation and find the bleeder where you can coagulate. These are the principles which we follow to prevent injury to the ovary. So here subcapsular vasopressin is being given. So it helps in vasoconstriction. So temporarily there will be constriction as well as you will find the correct plane of dissection. And whenever you encounter bleeding means you are in a wrong plane. So come back and again identify where the correct plane is. This is again kissing ovaries behind the uterus. So how beautifully the hydrodissection is helping me. Even with scissor, if I cut, I can reach the correct plane. And the cyst just pops out easily. But this is not always the case. Sometimes there can be dense adhesions. And in such cases, it's important to keep the uterus acutely anteverted. So it's important to position the patient in the beginning so that your buttocks, the patient's buttocks are well beyond the edge of the table. Now, sometimes there can be multiple users at the bed of the cyst or in the cyst wall. So putting in a gauze, keeping the count on the board written and telling the circulating nurse about it, it's a very good idea to just achieve hemostasis by keeping the ovary packed for some time. Now, where do you need to suture? Should you suture? Should you not suture? See, in medicine, there is no, there are always gray areas. So if I have a very large cyst wall which is ragged and into pieces, then I may want to suture it with 3-0 vicryl or something very light, very fine scar. At the end of it, I may want to see the ureters for peristalsis. It does not always confirm that there's no injury, but then at least you're sure when you're seeing clear urine and good peristaltic movement. Peritoneum may be involved. It could be angry looking peritoneum. So when you put in your scope, you know this is endometriosis peritoneum. You can make out those spots everywhere. You can see those spots everywhere near the uterocles, peritoneum. So peritoneum also needs to be removed in such cases. The rectum is also pulled up. The ovaries are not that big, but still there is disease everywhere. Ureters have to be dissected. I feel make your ureters, dissecting the ureters a habit, especially for such cases if you're planning to do such cases. Because if you keep them well exposed, you're always knowing where the enemy is and you can stay away from that. The ovaries have been suspended in this video, which you just saw. And then you have space to work in the center. And then you excise all the peritoneum which is diseased. Endometrial nodule in posterior peritoneum. Here, so again, ureter is being, the perirectal spaces have been created and then finding the nodules and removing them. Now, this is a case of bladder endometriosis. It was reported as a degenerated fibroid in the lower uterine segment, this case. So once I finished adenomyomectomy, this is another case. I'll come to bladder later. This is a large endometrioma which is being excised. So the same case of bladder, we first finished adenomyomectomy, and what was reported in MRI also as a degenerated fibroid was found to be a bladder endometrioma. So you have to do in the bladder, you have to make an incision, cystotomy, excise the entire nodule, making sure that you are away from the ureteric openings. If required, if you're close to the ureteric openings, you may request the urologist to do ureteric catheterization. In this case, we were far away, so then I repaired the bladder in 2 layers. The inner layer with 3-0 vicryl, and then the second layer checked with methylene blue for any leaks. It need not be watertight compartment, but you have to achieve good repair approximation of tissue. And I placed an omentum flap between the bladder and the uterus to prevent any fistula formation later on. How to prevent ureteric injuries? Because that is the biggest fear when you're dealing with the lateral pelvic spaces. Even a simple endometrioma, when you lift up the ovarian fossa may keep on bleeding. So this blind thing cannot be done when you're closer to ureter. So it is always better to dissect the ureter. This is a very old clip where sometimes I would myself put in the ureteric catheter and make it prominent. But now I know this is a ureteric catheter. It's very easy how you do tubal cannulation. But now I know it is better, much easier for me to dissect the ureter in the beginning of the surgery, even if I feel doubt in the middle of the surgery, and to visualize them rather than using all these guide wires and all. Another large endometrioma. So I know when I come to the base, it is going to ooze and I will require dissection of the ureter. So better do it when you're not tired at the beginning of surgery, when the field is not messy. Otherwise, chocolate fluid and blood, everything stays in the field so much that you may not be able to appreciate the angry looking peritoneum and the proper spaces. Now, this is a TLH being done for severe endometriosis. Be prepared for these adhesions. Sometimes it's a combination of a very large uterus, severe endometriosis, and previous 2 or 3 cesareans. So you have adhesions everywhere in all compartments. Again, identifying the ureters, keeping them under view. Once you've seen the ureters, you can use your energies safely if there is bleeding anywhere. And you can use a gauze or irrigation, small spurts of fluid, and then check where the bleeding is coming from. It can be extrapelvic endometriosis involving the appendix. Ideal treatment would be appendicectomy, but sometimes these are spots which cannot be picked up in MRI most of the time. So here, at least you can fulgurate these spots and leave the appendix as such because consent has not been taken. Rarely, it can be malignant where you're least expecting it. This was a young lady with bilateral large endometrioma. So when they're very large, you be suspicious, or when they're rapidly growing, again be suspicious, or CA125 is like 2,000, 3,000, again be suspicious. So as I put in my scope, I found I took peritoneal fluid, and I found these papillations on the surface, this growth on the surface, and they were too large to be removed. And she was a young girl who wanted ovarian conservation. It didn't seem appropriate to me, so we opened up laparotomy, and these were the huge cysts. Even through laparotomy scar, they were difficult to remove. And then Frozen reported it to be borderline malignancy. So we removed maximum part of the this particular ovary and left only a small ovarian tissue on the other side. This patient was lost to follow-up. It was mucinous adenoma borderline. And bubble injury also has to be prevented. We always do air saline test at the end of the surgery by filling the pelvis with saline and pushing air from below. So most of the time it's negative, but sometimes you may find air bubbles and then you suture them on the table. So that's the end of my video. I'll share 1 or 2 more videos with you before I move on to the PPTs. I have another video. I will share another video. Just give me 1 minute. So robotic surgery has made life really different, and people talk about it. It's justified or not. It is more of a gimmick. It is more expensive. But I feel that it has a lot of roles, especially when you have oncosurgery or when you're doing advanced robotic surgery for advanced disease of leproscopia, of endometriosis. So we'll move forward from here. Chia septum, we move to robotic surgery. So in this patient, see, we follow so sure. So sure, we'll see just now on the slides. Always expose the ureter, cut the congenital adhesions of sigmoid. Is my second video visible? Is my video visible?
Yes, madam.
Hello?
Yes, ma'am. Yes, ma'am. It is
Hello,
visible.
Dr. Harshini, is my video visible?
Yes, ma'am. It is visible.
I can't hear you, Dr. Harshini.
Ma'am, it is visible. Can you hear me, ma'am?
Can you hear me, ma'am?
I
It is
think,
visible.
ma'am.
Is my video visible?
Yes, ma'am. Yes, ma'am.
That's why I stopped. Yeah.
I think you were not able to hear us. We were all saying yes.
Yeah. Okay.
Yes.
Okay. So again, we pararectal spaces are very important because posterior compartment is all occupied with adhesions from everywhere. So cutting off the area which is medial to the ureters and lateral to the uterosacles, that is the lateral pararectal space, the lateral space, and then finding the area between rectum and the uterosacle, that is the medial pararectal space, or we call it the Okabayashi space. So here you may find nerves, hypogastric nerves. One has to be careful not to injure them. I'll keep forwarding this slightly. You deal with the endometrioma. And then these ovaries are falling in the center, in the POD. So it's a good idea to make your needle straight and take them through the abdomen and stick them to the abdomen with an artery faucet. And you keep them at traction. So now you have space to work in the POD. A gauze comes very handy because your instruments ports are limited. So you have to keep on using a gauze for giving clear picture. This was a laparoscopic surgery. The other one is a robotic surgery. The ureter one, which I'm going to show you. I'm just fast forwarding it slightly. So ureter peristalsis is checked. How do you identify the ureter? That is by the peristalsis. And you check them at the brim. It is easiest to diagnose them from the brim. Now here the rectum is adherent to this uterus. So when you're using energy, you can be, the uterus is acutely anteverted. You have kept it anteverted by the assistant, and the rectum, if required, you can put in rectal probe so as to create a V, a space between the rectum and the uterus. That's the rectal probe. And then you can also put in your finger sometimes. Like in this patient, I'd put in my finger through the vagina to show where the nodule is. Here, that's a posterior fornix. You can see my finger is moving it. So I know on my finger in the vagina, or then guiding the assistant to keep the finger there, I can cut this. In the later part, one may use not use electrical energy and may use scissor And you can feel that, even with laparoscopy, you can feel that gritty feeling, the hard feeling when you're on the nodule. And it doesn't bleed. It is usually scar tissue, so it doesn't bleed. So our idea is to put all the, excise all the tissue and leave it on the rectum and then shave the nodule which is there. Forward it slightly. Now, the entire nodule has come on the rectum from the space, rectovaginal space. The rectovaginal space is now free. After this, you pick up the nodule, maybe with a tooth grasper then cut it with a scissor. So see, now I've put my energy away and I'm using a simple scissor. So even if little serosal damage happens, there's no problem, because you all must understand that intestine has got multiple layers: circular muscle fibers, longitudinal muscle fibers, submucosa, mucosa. It's like onion. You keep on peeling the onion. Similarly, all these layers are there. So little damage to serosa with your scissor will not have any problem. If required, you can put in sutures with 30 later. So most of the tissue is getting excised, and it's important for your pathologist also to understand what tissue I have said. Usually they have no idea, your pathologist, your radiologist, what you want. So it's a teamwork. Here you see so nicely and the assistant has put the bowel on stretch near the promontory. She's pulled up the bowel and I'm holding this with this traction I'm getting, in which I'm cutting this tissue. So at the end of it, you do the check again, bowel check, ureters check, peristalsis, everything. And if required, you can do some, you can take 1 or 2 sutures. And that's the end of it. My third video about ureteric, my one more video about ureter I will be sharing now. Ureteric involvement. This is a robotic surgery. Here we use ICG dye quite a lot, but in this case I have not used it. See it. I hope you can see the video now. So this is the left ureteric nodule. She had a lot of dysmenorrhea, this patient. So initial adhesions are being lysed. That's robotic surgery. So it's as if you're sitting inside the abdomen. Then first the sigmoid adhesions are taken care of. Now the left side is forming a TO mass. The complete left side is forming this mass. There's a hydrosalping. So you first separate the sigmoid adhesions. And while doing this only, most of the time the cystic fluid, the chocolate fluid comes out. So the beauty of these movements, you can just go and turn it's as if your wrist and your fingers inside. Now again, in this case, the interesting part was sigmoid had also come and formed a nodule on the ureter. So the ureter is being dissected. Subtraction on the sigmoid as well. So you see sigmoid beyond this is totally free. Above it and beyond towards the rectum, it is absolutely free. It's only adherent to the ureter. So I'm using a gauze intermittently. And magnification and so much control on the energy really makes a difference. In laparoscopy, on the same wall, my instruments would have been parallel. And if I had used energy, I would have sent a little spur to my ureter also. Here, I'm just going and pinpoint energy I'm using on the ureters. So like a bridge, you hold up the tissue, make a bridge, and then use energy to keep it away from the ureter. So nodule is being dissected away from the ureter. Again and again, I'm using my gauze. Gauze is helpful because it gives you hemostasis. You can do suction on the gauze, put the gauze and then do suction so it doesn't cause trauma to these vital organs. And then the sigmoid is being separated. So you see the bowel ahead of it is totally free. So ureteric nodule is made free now. And then the nodule is cut. That's the nodule. Even the uterocycle has been involved, and there were a lot of chocolate spots on the uterocycle. So part of uterocycle had to be excised. See, you can see the chocolate colored spots on the uterocicles, left uterocycle, that was also excised. It was all disease. The endometrioma was on the right, but all this disease, the ureteric nodule was on the left. So best of MRIs also depends on the person who's reporting this MRI. If you find such bleeding, you can just put a gauze, and then if required, most of the time the bleeding stops. If required, you can take a stitch in this, and the ovaries were a little sutured. So I'll quickly run through remaining slides, and I think share slides. So ovarian endometrioma we have discussed. If you drain the cyst, they will come back in 6 months. If you just drain and coagulate, they will come back in 3 years, 57%. In 3 years, if you drain and you remove the cyst wall, also 23% will come. So just to remember, 2 years, 20% will come back, 5 years, 50% will come back. There's a 2.4% risk of ovarian failure whenever you're doing endometriomas. Should you give hormones pre-operatively? Not really required, because that will hide the planes, and microscopic disease will be hidden. Peritonectomy, butterfly peritonectomy is a new concept. Even Ellen Masters windows, if you're finding those windows, you should open them up, because deep there could be the disease here. This is fulguration of spots which is being done. This is the how you should be guided. So sure, it's called so sure steps of endometriosis. Survey of sigmoid mobilization, O for ovarian mobilization, suspension of uterus and ovaries, ureterolysis, rectovaginal parectal spaces creation, and accession of all visible disease. So all the videos you have already seen, I'll cut. This I want to show you how bowel injury actually looks, because you must be seeing a lot of videos where bowel injury they test but nothing happens. I want to show you how it really looks when bowel injury happens. I hope my slides are visible. So this, somebody's pushing the dye from below, and you can see it here. When you push the dye, suddenly you find bubbles. These are the bubbles, how it looks. So then you can repair these slides. We'll remove all this we have seen already. And ICG dye really works well in these cases. Pre-sacral urectomy and laparoscopic uterine nerve ablation has no role now with such wonderful devices, LNG, IUDs, and others. Post-operative HRT, should you give? Immediately within 3 months, you should not start HRT, because that should be the time given for all the inflammation, everything to settle down. With after that, one may give it HRT, preferably with progesterone combination, that to low dose combinations, continuous, if the patient is symptomatic. And one last video I want to show you is this is how there's something called firefly mode in robotic surgery. Even in laparoscopy, there are some like Stryker and all of come up where they have this possibility where you have fluorescent catheters. So here we are putting through cystoscopy catheters and injecting ICG, indigo cyanine green. And when you click the firefly mode, you see the ureters beautifully, and this stays for quite some time, 2.5 hours it's safe. So intermittently, you can just click the button firefly on, and you can safely continue with your surgery without having to dissect the ureters. That's an added advantage. And I feel that robotics is not just a gimmick. It is really helpful, especially for such diseases. You may say for a small fibroid, you may do laparoscopy, but for such extensive endometriosis, I still feel that robotic has a long way to go. So I think most of the things I have said. If I have time, I'll continue with my slides. Otherwise, I'm done. Hello, Doctor.
Yes, ma'am.
Yeah, so
Thank you, ma'am, for such
whatever I've said. So let us all join hands and free our women of this debilitating disease. It keeps coming back and frustrating for the patient as well as for us. I thank you all for a very patient here.
Thank you, ma'am, for such an insightful and technically enriching presentation, ma'am. Your surgical videos, including those robotic assisted dissection of DIs, the rectal nodules, they beautifully demonstrated the advantages of the 3D vision, the enhanced instrument dexterity, and even greater precision during a complex pelvic dissection, ma'am. Thank you so much, ma'am.
Thank you, madam.
Particularly
Thank you,
that firefly fluorescence, no, ma'am, for enhanced intraoperative visualization. It was very particularly interesting. Thank you, ma'am.
Thank you very much. Thank you, Ramani.
Dr. Jyoti, thank you so much for for your presentation. See, I have a bad cough.
Thank you. It was nice to see you online. Thank you very much.
I was in the middle of a surgery.
Thank you.
That's right.
So, Niveta ma'am, kindly introduce
Yes.
Jayesh Amin sir. And I'm actually very proud to say that I was one of the fellow at sir's Wings Hospital in reproductive medicine. So, over to Niveta ma'am.
Yes. So we now have Jayesh Amin sir, who's going to discuss an interesting and emerging field, the role of stem cells in endometriosis. So sir is a clinic director, a reproductive medicine specialist of Nova Wings IVF Group. He's the HOD of Nova Wings IVF Academy, a national strategy developer of Nova IVF Wing, the president of Association of Reproductive Genetics and Immunology, the chair-elect 2005 to 30 ASRM Ovarian Insufficiency SIG. National leaderships, national advisor of IFS, organizing chairperson of IFS Fertivision 2024, East Additional Joint Secretary of IFS. He was a past convener of Fertility Preservation Society and also a past secretary of Gujarat IFS chapter. His academic achievements and contributions are he has authored practical books on assisted reproductive technology. Sir is the founder of IVF and Embryology Training Academy. He has international presentations at ESHRI and ASRM done. He has trained 200 plus gynecologists to become IVF specialists. And he has won this Excellence in IVF Treatment Award at Government of India in 2016 and also an Gold Award in Excellence in Reproductive Endocrinology in 2024. Over to you, sir.
Thank you for kind introductions. And I'm just sharing my slide. Yes, that is. Wait. Yeah. Full कर दो full. Fine. इसको ये हटा दो. 1 minute just. Fine. I think so. Since it's not working. Yes. Fine. So today's topic is something which is bit we all people are not that much of practicing, but might be it will be the future. And we are periodically practicing in our day-in-day routine life, but still there are concrete data which was not arrived. More of the studies which was on more on the animal studies and very least study which was on the human. And specifically we want to today's know about this stem cell, that how they will definitely help in the endometriosis. And when I'm talking about this paradox, why should stem cell matter in endometriosis? Today, I want to discuss a topic that sits at the intersections of the two fascinating areas of reproductive medicines, endometriosis and stem cell biology. When we hear the words stem cells and endometriosis, there is an immediate question that comes to mind, that are stem cells contributing to the development of endometriosis, or could stem cell actually become a treatment of endometriosis? And interestingly, the answer may be both. And that is the paradox that I would like to explore with you today. Rather than simply asking whether stem cells work, I want to understand that which stem cells coming from where, doing what, and under which microenvironment that is most important. And let us start with the paradox. So endometriosis is traditionally discussed in terms of retrograde menstruations, implantations of ectopic endometrial tissues, inflammations, estrogen dependence, angiogenesis, and immune dysfunctions. But there is another biological property that is extremely important. The endometrium regenerates itself every month. Something capable of repeated destructions and regenerations must have a very efficient regenerative system, and that immediately brings us to stem and progenitor cells. So I can say like that endometriosis, as per the available literature, endometriosis affect approximately 10% reproductive age women and girls globally, corresponding to roughly 190 million individuals according to the figure used in these presentations. Yet despite this enormous burden, endometriosis remains undiagnosed, untreated, and incompletely understood. So why is stem cell biology relevant here? Because endometriosis is not simply misplaced tissue. It is a tissue that is capable of surviving, proliferating, invading, recruiting blood vessels, interacting with the immune cells, and maintaining itself in an ectopic environment. Those are exactly the kinds of biological behavior in which progenitors and stem cells populations may be important. So, uh, the before taking about endometriosis, we have to understand normal endometrium. The endometrium has two major compartments, the functionalis and the basalis, and where each month the functionalis undergoes a cyclic changes and is shed during menstruations, which is upper to two-thirds of the endometrium, while the basalis remains relatively preserved and provides a foundations for regenerations. And then, remarkably, within a few days, the endometrium reconstruct itself again. So the question is, where does this regenerative capacity come from? This cyclic proliferations and regenerations that occurs during each menstrual cycles was first proposed to the mediated by resident adult stem cells populations within the endometrium in 1978. And nearby 25 years later, the first evidence stem cells activity in the human endometrium was reported, and collagenic epithelials and stromal cells were identified, and over the years several different populations of stem cells have been identified in the human endometrium. So I want to show you that this slide that sorry what about this side populations. This is a study which was published in 2008 regarding side population cells contribute to the genesis of the human endometrium, and to investigate whether stem cells are found in human endometrial side population cells or not. It is an experimental laboratory study. It's a university-based laboratory in Japan. And one of the interesting early piece of evidence came from studies investigating side population cells in the human endometrium. In this experimental study, normal endometrial samples from 42 patients were analyzed using side populations analysis and panel of markers including CD31, 34, EMA, CD105, so on. So these cells showed characteristics associated with different cellular compartments. There are endothelial associated markers such as CD31, CD34, EMA suggested epithelial characteristics, and so on. There's so many other epithelial markers will be there. So let me tell you that in the next slide that I want to say that three type of stem cells in the human endometrium: the epithelial stem cells, the endothelial stem cells, and mesenchymal stem cells, which are basically demarcated by the markers, which is CD19, CD44, CD73, CD90, and CD105. So these are the three type of different markers will be, the different studies will be there. And in this regenerative cells are shed during the menstruations and reach the pelvis through the retrograde menstruations. Could they contribute to endometriosis? So we want to say that the interesting question that if these cells are highly regenerative and if menstrual cells tissue travels backward through the fallopian tubes during the retrograde menstruations, could some of these regenerative cells also reach the pelvis? And if they reach the pelvis, could they contribute the formation of endometriotic lesions? This give us the stem cell hypothesis in endometriosis. So the endometrial stem cell progenitor cells and their role in the pathogenesis, what they are rolling in the pathogenesis. And if you consider the role, then they do have some side population cells, the mesenchymal blood derived stromal cells and bone marrow derived different type of bone marrow derived stem cell. These all cells, we have menstrual blood cells, we have bone marrow derived stem cells, and we have endometrial mesenchymal stromal cells, including all the markers, many of which are described in the perivascular location. So rather than thinking about the endometrial stem cells, think of this an ecosystem of different progenitor and stromal populations. So the study which was did in the all study, most probably on the animal study will be there, and they use, when the anti-cancer drug, this is a sorafenib drug, they used, and they inhibit the growth, migrations and angiogenic potential of ectopic endometrial mesenchymal stem cell derived from the patients with endometriosis. So now we can say like that in the evolution of this, all this, the stem cells, endometriosis and stem cell, look at that 1920 to 1950, the Sampson's retrograde menstrual theory will be there, followed by the evolutions that endometrium contains regenerative and that it is established in 1990 to 2000 that endometrium contains some progenitor cells. In 2007 and 11, identification of characterizations of endometrial stem progenitor populations, and in the 10, that endometric lesions establishment, angiogenesis and disseminations. 20, we come to know that this menstrual stem cells plus organoids plus single cell transcriptomic approaches that we come to know. In 2026, we still add some secretome, exosome. So we are evaluated from the retrograde Sampson theory to knowing about there are stem cell in the menstruation, and nowadays we do have some secretome, exosomes, and some secreting media will be there which is taking part in the angiogenesis and maybe therapeutic therapies in the certain fibrosis, and the endometriosis will be there. Looking to that, then we are on this big paradox that stem cells may be both the problem and the solutions. That when we use this therapeutic mesenchymal stem cells may suppress the inflammations and promote the tissue repair through paracrine mechanisms. It reduces inflammation, it reduces angiogenesis, fibrosis, tissue repair, immune modulations, and we can say microenvironment restorations. And for that, we are using different variety of the stem cells will be there. So the other part that I want to share you that this is the mice study again, and it was found that when microRNA 199, which was suppressed, it was suppressed in the mice, those who are suffering from the endometriosis. First, they produce endometriosis and then they suppress this. So when they suppress, they found that the mice, those who are having a suppression of the microRNA 1990, they do have a chance less endometriosis development will be there. So this is where stem cell biology become clinically interesting. A cell that contribute to an endometriotic lesion must do more than simply survive. It must proliferate, it must migrate, and the lesion must develop a blood supply. Stem progenitor-like cells can be associated with angiogenic signaling, including VEGF. And new blood vessels provide oxygen and nutrients, and that support the lesion survival. So stem cell progenitor biology potentially connect three important features of endometriosis: proliferation, migration, and angiogenesis. And one particularly interesting study looked at microRNA 199A5P. The presentation shows that microRNA 199A5P was markedly downregulated in patients with endometriosis. And microRNA 1990A5P was increased experimentally proliferation, motility, and angiogenesis of ectopic stem cell populations were suppressed apparently thorough targeting of VEGF-A. And an animal model increasing microRNA 190A5P was associated with the smaller endometriotic lesions will be there. So here by this study we can say something about there is some clinical role we can find out. Then so far we have discussed. So now we are arrived at the paradox. So far I have told you that stem progenitor cells may contribute to endometriosis, then why are researchers studying stem cell as a treatment for endometriosis? Isn't that contradictions? If stem cell can help create the disease, why would we inject stem cell to treat it? The answer is that we are talking about different populations. So we are not talking about only the menstrual blood derived stem cells. We are talking about different stem cells. And which are they? Which are they? And look at the different stem cells. Apart from in the regenerative and endometrium, what the endometrium is providing, that menstrual stem cell is doing, but we are having a different sources. For example, before we go further, I want to clarify one very important point, because the term stem cell can become confusing in these discussions. We are actually talking about two different stem cell concepts. First, endogenous endometrial stem cell progenitor cells. The first are the stem cells. So left side, the pink side, you can say the first, the stem cell progenitor cell naturally present within our endometrium. And their normal job is actually very physiological. They help the endometrium to regenerate after every menstrual cycle. So these cells are essentially the repair and renewal system of the endometrium. But now consider what happens in endometriosis. If endometrial tissue containing these highly regenerative cells reaches the pelvis through the retrograde menstruation, and these cells survive and establish themselves at an ectopic locations, their very properties of proliferation, migration and angiogenesis may actually help the lesion established and persist. So in this context, these endogenous endometrial progenitor cells may be a part of the disease biology. But now comes the apparent paradox. And this brings us to the second group, the therapeutic mesenchymal stem cell or stromal cells. These are not the same cells that we are saying may contribute to the endometriotic lesions. Therapeutic mesenchymal cells can be obtained experimentally from the different sources. For example, bone marrow, adipose tissue, menstrual blood, umbilical cord, and dental pulp. So why would we give these cells to the patient? The important point is that we are not giving mesenchymal cells with the intention that they should become new endometrial lesions or replace the endometric lesions. The therapeutic rationale is quite different. We are interested mainly in what these mesenchymal cells secrete. So secretion is important. Now we come that what they are exactly what they are secreting. And look at that, the novel therapeutic approach. And this is again the animal study, that what these adipose cells are now going to secrete. And here, adipose tissue is an attractive source because it contains abundant adipose derived mesenchymal stem stromal cell, and they have regenerative and immunomodulatory properties. So what they did in this study, that they add this adipose tissue cells, and three things: only adipose tissue cells in the mice study, adipose tissue cells and conditioned medium, and they add the combination of adipose tissue cells plus conditioned medium. And the study was performed in a mouse model, and it is therefore preclinical, not human clinical evidence. And the published study confirms the experimental mouse design will be there. So here what they found, when they have a conditional medium, look at that, in endometriosis, this endometrium, they inject the mouse, those who are having endometriosis. And what they found, that the lesion size is reduced when they add conditional medium. So whenever the adipocyte cell, the conditional medium is more effective rather than cell alone, or rather than the cell plus adipose tissue. So the inference of this study is that here it's not adipocyte cells, it's all about the adipocyte tissues conditioned medium. The conditional medium, it is more effective, will be there. So now let me tell you the paracrine effect. So the adipocyte tissue, what they're going to secrete, the cytokines, the growth factors, the extracellular vesicles, and that is what inside the conditioned medium. And they are going to be reducing the ICM1, reduce the VEGF1, reduce the inflammations. Stop the mobile. Reduce the inflammation, reduce the angiogenic signaling, and reduce the experimental endometriotic lesion. better pregnancy outcome in the mice. So this is the condition medium. So that we are talking about we are talking about the condition medium of the adipocyte, which is helped inside the endometriotic mice. So now my next slide is uh, uh, the after that what we are talking about, that they the efficacy, but then what will be the limitation of this study? Now I want to be very clear that this is where we must separate biological possibility from clinical evidence. This study do not establish efficacy in women. This is all about the mice. They do not tell us the optimal human dose. They do not establish the optimal route. They do not establish the long-term safety. And they do not tell us what happens to ovarian reserve. They do not establish the improved outcome, and they certainly do not establish a live birth benefit in women with endometriosis. So at this stage, this is a preclinical evidence, no clinical evidence, specifically when we are talking about the mice. So now I am talking about the clinical use, the association between ovarian endometrial and ovarian reserve. When there is endometriosis, you know that endometrioma, there will be a compression, there is a chronic inflammation, it will be lead to oxidative stress, reduced blood supply, fibrosis, damage to the ovarian cortex. Ultimately, we have a follicular loss and decrease in AMH and AFC, and tend to will it because of the surgery also. Sometimes because of the pain, we need to do surgery. Again, surgery aggravate the fibrosis and everything by hypercoagulations, and it lead to a decrease ovarian reserve. So in that conditions, also the other more theory that we can say that how endometriosis will going to reduce. This is all about that ovarian endometriotic cysts do have some blood products, some iron, oxidative stress and inflammatory mediators, and these all the ferroptosis of the stromal cells. It leads to a ferroptosis of the stromal cells, and this all leads to the cascade of the cytokines arrangement, and the net effect, it is associated with the increased VEGF and ILT drive angiogenesis and promote progression of the ovarian endometriosis. So this is how the endometriosis is going to be produced. And this is how I want to show that what exactly I am doing in my clinical practice, that mesenchymal stem cells in regenerative medicines. So how I am using, this is my own where there is a patient, those who are having a decrease ovarian reserve. It's maybe because of the certain different causes, but it may be because advanced at maternal age, it may be because of the surgery, it may be because of the endometriosis. Now patient, those who are having a decreased ovarian reserve, here we are using the mesenchymal stem cells from the bone marrow. Specifically, this is my bone marrow stem cell that we are injecting inside the ovary with bone marrow stem cells with the exosomes will be there. So how they are going to be effect, and this is which are the different type of in vivo in vitro technique that I'm using in my clinical practice. One very something which is I'm doing more commonly in the decrease ovarian reserve, it is called ovarian pricking. I believe that rather than PRP, I'm doing pricking of the small ovaries when the patient is very younger, and before, I think so, in the first 7 days of the menstrual cycle, where I can do. So it's all mechanical irritation. When you do mechanical irritation, that leads to the increase of the growth factor inside the in vivo. And I'd seen something where decrease ovarian of younger patients, we do have a every 10 days we can monitor the ovaries, and we found a very good response compared to the adding PRP. So that is what I'm very frequently doing pricking rather than PRP. But if this ovary where is not responding to pricking, then definitely we are doing two technique, and one of the technique which is laparoscopic endometrial stem cell, where we are doing the firstly we started with the bone marrow stem cells, and we are injecting the bone marrow stem cells in the cortex with the help of the laparoscopy. So we don't believe the intravaginal, then we are always believe that laparoscopy is a better route where we can precisely inject inside the cortex. So this is how we are doing the injection of the stem cell inside the ovary, specifically when there are decreased ovarian reserve. This is all the mechanism action. I don't want to show again, but I can say up something what the overall ovarian rejuvenation principle will be, that in vitro mechanical irritations. So when you do PRP or when you do prick, so that is what I'm saying, pricking is sufficient rather than to PRP. And that is why I intravaginally I will prick the ovaries, and if the ovary is too smaller, I also pricked by laparoscopically, but I still deliberately I'm not adding PRP. But I do have a good response, specifically younger, and the volume is good and AMH is too low. So where the in vivo mechanical irritations will be there. In vitro mechanical irritation, I think so EVA technique is there, but still I'm not that much of experience for that EVA technique, where we don't have that much of good output by the EVA technique. And later on, I think so we are using by stimulation by the stem cells. So we are adding the stem cells specifically when the ovaries are having a decreased ovarian reserve. What will be the, this is my own slide, that what is the mechanism action? It is nothing like that. When you do mechanical irritations, or will you add some growth factor? Mechanical irritation, that means you are pricking, then some growth factor. So this growth factor, you can see the tank where they require growth factor. It is all about the engine. Ovary is an engine, ovary is a car, and I think so where you can, the fuel is growth factor, and the PFC, that means primordial follicle, are the engine will be there. And when you prick or when you add this growth factor, the PI3 AKT pathway act as an accelerator. They will increase the cellular hyperplasia, and that's why they are going to negatively affect the P10. So these are the brake. P10 is a brake, so they will negatively affect the brake, and that's why the cellular hyperplasia, because of the adding the stem cell or pricking or adding the growth factor. This is the basic mechanism that we can understand, that how the all cellular hyperplasia, why primordial follicle will get more accelerated to become the antral follicle, and you can go ahead with the stimulation in your clinical practice. So this is how the basic that we can understand. Another one thing is that the study, so when you're talking about mesenchymal stem cells, and in 2023 systemic review and network meta-analysis, the Cochrane review of 2024, PRP versus stem cells. And what we observed, that these slides compare the two generative approaches. Is we are using PRP is good or stem cell therapy based therapy is good. Both are biologically attractive, but neither should be presented as established therapy for endometriosis on the basis of current evidence. So the important principle is that exciting biological results should not automatically become clinical treatment. So both approaches, we need a properly designed a trial looking at clinically meaningful outcomes, particularly pain, recurrence, fertility, and live birth in the future. So this is the video that I want to show you, that how I'm laparoscopically we are using adding a stem cell. So we are just holding the ovary, and then we are just injecting with the ovum pickup needle. So you can see that ovarian cortex, we are injecting inside the ovarian cortex. This is a stem cell, and then we are adding some fluffy plasmas surrounding that. We are also doing, we already started something adipocyte stem cell also to injecting inside the ovary also. In a certain case scenario. So this is how we are using in our clinical practice when the patient, those who are indicated, when they do not respond to the stimulation, they do have a decrease over reserve, small size, or younger patient with less AMH will be there. The next slide will be here. This is the photograph, but I think so my video is not working. I think so we completed certain collection of the adipocyte stem cell, because if you see, I'm showing something in my next slide, that how adipocyte, because bone marrow, where you can have a bone marrow, you can have a stem cell, but the number of the stem cell will be lesser. So it will be more useful when you are using in the endometrial regenerative therapy. But when you are talking about the ovarian regenerative therapy, here there are some study, beautiful study, or some case report is also published in the American Fertility Society, where they are saying the adipocytes are more stronger. But I think so we need more trial in the future. We tried in a 3 or 4 or 5 patients where we are collecting the adipocyte cells and regenerating the adipocytes tissues, and then isolating the adipocyte stem cells in the millions, because in the bone marrow you can have in the lax stem cell, but in the adipocyte cell we can have a million stem cells that we can inject inside the ovary in the same way that what we are using in the bone marrow stem cells. The mechanism actions, you people are knowing that. I don't want to discuss about the more about the mechanism actions, but this is how they are going to the work on the regenerative therapy in the ovaries. Now this is a very good. Now let's talk about the adipocyte stem cells. So the systemic review and meta-analysis which was published, a bunch of the study which was published. A recent system is that 20 preclinical studies, 7 were exclusive in vitro, 11 used in animal models, so 18, and 2 used in the both in vitro and I think so in vivo. In vivo, when I'm talking in vivo, it's animal models, not the human model. And the most commonly investigated cell source are adipocyte cells, so adipocyte stem cells and bone marrow derived stem cells. So I would like to show some graph that which is more effective. Look at this graph here. So here there is no doubt about it. Now the data is now toward the adipocyte stem cells. The green is a positive effect. So you can say that adipocyte stem cells might overcome in certain regenerative therapy in the future. We need some more data, but currently the most extensive study and showed the greatest number of the reported beneficial effect on these experimental models, but some negative and neutral findings are well also reported. So this is how we are progressing in the use of these adipocyte cells. And this is when I want to show something here. Sorry, this is systemic review, and that is sorry, just this is the stem cell based therapies approach systemic review. And here I show that the green effect, which shows that how adipocyte stem cells are having showing a good effect on the regenerative capacity compared to the only two adipocytes and bone marrow, only two that they are having a more green effect will be there. And look at that here. What about the reduction means when you add this adipocyte stem cells in vitro and in vivo, then we can say we ask what the stem cell actually did. The strongest signals were seen particularly in adipocytes in reduction in inflammation, reduction in proliferation, reduction in cyst or the lesion size. This is what we are talking about the endometriosis. Reduction in the fibrosis, and in some models effect of angiogenesis and apoptosis which was observed. So green, it is showing something about the positive effect, and the other colors you can say in vitro, in vivo, in both that we can say. So let me tell you another thing. This is how the paracrine effect. So if stem cells can produce all these effects, what is the actual mechanism? We know that there are something which is called secretosome and exosome, miRNA, immunomodulations, and anti-angiogenesis, anti-fibrogenesis. These are the mechanism of action that we can see when we are injecting it. And this is the beautiful that this figure takes one step further. We have already seen what stem cells can potentially do in experimental endometriosis. Now we need to ask, how are these therapy actually being delivered? The authors derived the intervention into direct administrations or of live stem cells and administration of the stem cell derived products such as conditions medium, extracellular vesicles, and exosomes. Right? Across the reviews, the study, 60 reported effect were associated with the direct stem cell administration, 28 stem cell derived products with only 4 effect associated with the combination approach. So we can say stem cell is more effective and the stem cell derived products will be more effective. That is what we can say in this research. And the next slide, you can observe that which are all the mechanism that already I discussed about all the mechanism. So now let's say something about, we can discuss about the emerging role of the menstrual. This is all of the adipose cell, and now we can see the emerging role of the menstrual blood cells. So menstrual blood cells, I think so we are first discovered in 2007, and this cell are first this is particularly interesting because menstrual blood is easily accessible, and this cell may provide relatively accessible source of studying endometrial regeneration biology. But the stem cell theory of our endometriosis pathogenesis, supported by the consensual mechanism of retrograde menstruation, highlights the recognized importance that menstrual stem cells have gained by potentially being directly related to the genesis, developmental, and maintenance of ectopic endometriotic lesions. Meanwhile, this difference observed between the menstrual stem cells in patients with endometriosis and healthy women underline the applicability of these cells as a putative biomarker for the early diagnosis of endometriosis as well as the development of targeted therapies. So if it is expected that in the near future menstrual stem cells will have the potential to change the way we manage this complex disease once their long-term safety and effectiveness are assessed. And another one more study that which is promising effect of exosome. So when we are talking about adipose stem cell, that means conditional media is important. When we are talking about menstrual blood cell, that means not menstrual blood cell stem cell, but more exosomes. So here exosome is more important. Treated with exosome derived any menstrual stem cells to modulate their gene expression. So now you can get the point that in adipocyte stem cell, condition media is more important. In menstrual blood stem cell, I think so the exosome derived menstrual blood stem cell are more important, will be there. Now talking about some other stem cell, that mesenchymal stem cells. So here we are talking about mesenchymal stem, therapeutic application of the mesenchymal stem cell in endometriosis. I think so it's a big meta-analysis which was published collecting the study from 2006 to 16 to 2024 and examined the role of mesenchymal stem cells and that derivatives and endometriosis pathophysiology, diagnosis and treatment. And I think so here, one minute. Here I want to show you something that how they are going to the green effect, which show that how this mesenchymal cell is effective in endometriosis. And lastly, I can say the how measure target the core derives of the endometriosis. The mechanism of action is immunomodulations, antifibrolytic activity, angiogenesis modulations, promotions of apoptosis in ectopic endometrial cells, and restorations of endometrial receptivity. So these are the all the studies which was published for the mesenchymal stem cells. This is meta-analysis, which is more about the animal studies are there, but which shows something a better output effect in the role of the mesenchymal stem cells in the endometriosis. But before we talk about the effect, we should also talk about the limitations and the honest caveats. And I think every discussion about stem cells must end with an honest discussions of limitations. Pain reductions, if achieved, may be variable. Mesenchymal stem cell therapy is not a cure for endometriosis. We do not have a large randomized clinical trial establishing efficacy. Fertility outcomes remains uncertain. Optimal cell source dose and schedule remain undefined. Long-term safety data are limited. And there is another issue that we must never forget. Endometriosis is a disease of young women, often during their reproductive years. So any regenerative or cellular therapy must be evaluated not only for short-term benefit, but also for long-term safety. So still it is long-term safety is we are not having long-term safety issues are there. And looking to that, I think so lastly I can the conclude that stem cells have a dual role in the endometriosis. It's not only in the pathogenesis, it's also we are talking about that from adipocyte to menstrual blood cells to the mesenchymal cells. They are also with the secretomes and some other cellular media. They do have some anti-inflammatory, anti-angiogenic, antifibrotic, and potential lesion regressions which was found by these cells. So we are looking for definitely at the end of the day, what I am saying that yes, adipocytes do have a more positive effect. So we are looking for more adipocyte tissues, stem cells, and the regenerative theory, the publications in the future, specifically in the human, or maybe whatever the applications will be there, we can have some long-term studies to the in the human that where we can find out which is best. But at present, I think so adipocytes are having a more positive green signal. Second, bone marrow mesenchymal is also second, and we are waiting for that extraction of the menstrual stem cells theory may be a future to treat this endometriosis. So with that, I think so I tried my best, because something which is this topic is too much difficult, and I tried my best. I know that as a therapeutic, I already talked about that I'm doing pricking in my clinical practice, specifically when reduce ovarian reserve, and it's really effective, too good. But I believe after pricking, I'm just shifting toward the stem cell, bone marrow stem cells, or maybe now I tried adipocyte stem cells in the ovary for the decreased ovarian reserve. I still did not use it in my practice that to reduce the endometriosis. I still not tried, but these are the evidence which was published. And I think so for the endometriosis, that maybe it could be a treatment for the future with the evolution of the and with the good randomized control trial. Thank you so much.
So thank you, Dr. Jayashamin, sir, for the excellent and thought-provoking section, sir. You gave us valuable insights into the emerging role of stem cells in its pathogenesis as well as its potential future management of endometriosis. Thank you so much, sir.
Thank you.
Dr.
Moving
Jayesh,
on to
thank you once
Dr.
again.
Thank you, ma'am. Thank you
Thank you
for
so much.
inviting me.
I
Thank
think
you.
you have, yeah, it was a difficult topic. Still, I know you can do it to the best of your ability. And
Yes.
as you have rightly pointed out, young women with endometriosis, we have to be very careful about using stem cells because we do not, it is still in the primitive stage and we do not know the adverse effects also. So, limited one. And probably, as you say, that menstrual blood stem cells might be a good option
Good
because it
option.
is available in plenty and then non invasive also. But whereas when
Yes.
you're going to take the adipose tissue bone marrow, it is going to be very, very cumbersome and painful to the patient. So, thank you so much for your input. Thank you.
Thank you. Thank you, ma'am. Thank you all.
Yes, ma'am. So moving on to Dr. Vidya Tobi, ma'am, who's going to address on the dietary modification in endometriosis pain. So madam is a professor and a former head of Department of OB-GYN AMC Vijaypur, president of KSOGE at 2023. She was a chairperson Food, Drug and Medical Surgical Equipment Committee of FOXI in 2018 to 2020. She has won the Best Committee FOXI Award, Dr. Mehru Dara Hansotia 2020, ICOG Governing Council member of 2023 to 2025. She has won the Foxy Champion Award of 2019. She is the national corresponding editor of Joggy. She has been the organizing chairperson of KSOGA 2023, the president Bijapur OB-GYN Society of 2009. She was the secretary Bijapur OB-GYN Society of 2007. She had done many publications in various books and contributions to Foxy, focus and speaker at national and international conferences. She has done papers at national and international conferences, organized various CME workshops and awareness programs. She's been the advisory faculty of boards Rajiv Gandhi University of Health Sciences, postgraduate and undergrad teacher for 37 years. Madam is the NABH Manyata Assessor and State Advisory of PCPNDT and a technical expert at maternity mortality and author and editor of many books. Also Foxy Gestosis HPP Guidelines expert. Over to you, ma'am.
At the outset, I must thank the Endometriosis Society of India, as well as the president of this Endometriosis Society of India, Dr. I think Mahapatra. I think I'm audible, Harshini.
Yes, ma'am, you're audible, ma'am.
Yeah. So I thank President ESI, Dr. Mahapatra, and Secretary, Dr. Mitra, and my hearty thanks to Dr. Ramani, who is always my mentor. So I wish her a speedy recovery, though she has joined, though she is traveling, she has joined. Thank you very much, Harshini and others who are the backbone of this webinar. I'll share my presentation. Yes. Thank you very much. And today the topic which is given to me is dietary modification in endometriosis pain. So we all know that endometriosis is a condition which has got a lot of inflammation. And why we are today talking about nutrition is endometriosis does have some part that people say that this you should eat, this will cause more inflammation, this diet you just don't take, all those confusions were there. I think that's why this topic has come up, and I wrote this topic in some of the focus, which is edited by Dr. Ramani. So, endometriosis is an inflammatory condition, and nutrition may play a supportive role in reducing this inflammatory burden. A balanced eating pattern may also support hormone regulation, bowel health, and general well-being. Nutrition should be presented as one component of comprehensive endometriosis care and not as a replacement for medical or surgical treatment. So I have seen many advertisements, many reels which are provoking that only these nutritional interventions can treat endometriosis, but it is not so. It all depends on the severity and other staging also for the endometriosis. We all know that estrogen component and other components also, they cause very much inflammation, and the dietary fiber. Then what is important is the healthy microbiota. So a lot of publications are there for healthy microbiota also, which also reduces the inflammation. So ultimately, we talk of reducing inflammation by various means. Now, what is a key message what we can give to the patient? There is no specific diet which has been shown to cure endometriosis. Dietary changes may help for some patients which feel better. They feel better, but the responses that varies from person to person, and it really avoids creating guilt. Patients should not be made to feel that their disease persists because they did not eat correctly. The goal is sustainable, nutritionally adequate pattern that supports health while the underlying condition is treated appropriately. So we know that the endometriosis, the diet, whatever the patient is taking, one is mostly we advise them about the fiber and vitamins. Carbohydrates, proteins, of course, they have the major diet what we consume, and the trace minerals and grease, these are the other parts. So diet is a supportive. So we all know that the diet may be what might be doing is it support overall health, bowel function, and possibly the symptoms self-management. What it cannot do, no specific diet has been proved to eradicate the endometriosis or replace evidence-based treatment. And that's why the counseling is very, very important. Aim for sustainable, nutritionally adequate changes. Avoid blame and extreme restriction in the diet. So what food might influence? So one is nutrient or various food groups. We know that what is, if you see this food map, the main is fiber, dietary food, or which omega-3 or Mediterranean type of diet. And this diet definitely should be included, which should not be included, we should advise. And the key players are the gut microbiomes, estrogen, and inflammation. So you should advise this type of flu food which reduces the inflammation. So omega-3 definitely reduces the inflammation. Then you should ask them to avoid red meat because it promotes estrogen and then increases the inflammation. Dairy products should be less, but the fiber should be more. And the gut microbiomes, we all know that it affects the immune system. So these are the important things you should know. You should emphasize on fruits, vegetables, nuts, seeds as an antioxidant rich, minimally processed food. So processed food and which contains lot of preservatives should be avoided. The diet should include omega-3 sources like fatty fish, walnuts, chia, flax seeds, and suitable plant oils. And we should always prioritize fiber-rich whole food, vegetables, whole fruits, legumes, and whole grains. And we should also include the magnesium-rich foods such as leafy greens, nuts, seeds, beans, and selected fruits. And also the healthy fats such as olive oil, avocado, nuts, and seeds. The provided gist, that these are the, if you tell them, they will not understand. So the fiber, if we tell 35 grams per day of fiber, which contains soluble fiber and insoluble fibers, and whole fruits and vegetable, which are the preferred one over juice. Fruit juice is not having fiber. The useful sources are ground flax seeds, beans, lentil, chickpeas, whole wheat foods, and brown rice. So we have to increase these gradually. Sudden increase also may worsen the gas, bloating, and abdominal discomfort. Pair high fiber intake with adequate hydration. In deep endometriosis, we all know that there is a dysphagia also. So, of course, you have to ask them to drink lot of water and avoid constipation. Now, what about omega-3 and healthy fats? What are the food sources? Fatty fish, walnut, chia, and flax seeds, olive oil, and avocado. And omega-3 fatty acid can influence inflammatory lipid mediators, monosaturated fats, which fit a cardiometabolically healthy dietary pattern. And evidence caution is plausible uh, anti-inflammatory effect do not equal proven endometriosis pain treatment. So prefer food first advice. Magnesium and zinc. Magnesium stores, we know that leafy greens, bananas, papaya, avocado, blackberries, beans, almond, and pumpkin seeds. Useful for nutritional adequacy. Supplementation is not established. Endometriosis analgesia. Zinc, again, the sources we know the poultry, shellfish, eggs, and other dietary sources. Plant-based diets also need adequate zinc. So frame zinc as a nutrition and not disease-specific therapy. We know that in immunity, zinc increases the immunity. So what to limit again? So highly processed food should be limited, especially patterns high in refined carbohydrates, added sugars, saturated fats, and excess salt. I think all bakery products should be avoided. Prefer natural in minimally processed alternative whenever feasible. Red meat, the gist advises limiting high consumption of choosing the leaner portions. Caffeine may be an individual trigger. Assess the actual symptom response rather than banning it universally. Making substitutions gradually, sustainability matters more than a perfection. So usually suddenly if you tell them to stop, they may not stop. So it should be a gradual one. Food triggers are also very important. Commonly reported are alcohol, caffeine, gluten, dairy, and high sugar foods. Better approach is food symptom diary. Once sometimes some food we consume, the symptoms are more. You have to keep a diary, one variable at a time, and reassess the benefit, reintroduce when appropriate. And you should avoid multiple simultaneous exclusions, long-term restriction without indication, and nutritional deficiencies also do occur. So we have to correct them, and the patient should not have food-related guilt. The recent evidences about these dietary interventions, what was reviewed was 11 randomized trials involving 716 women. Interventions and outcomes varied substantially, limiting certainty and comparability. And what was the clinical interpretation was some interventions show promising signals, but there is still no validated universal endometriosis diet. So use diet as an adjunct and be transparent about uncertainty. So in 2025, this is the evidence check about the supplement. There was a pelvic pain and pooled mean difference was around 1 to 1, 1.1, 95% confidence interval from 3 to 0.8. So there was no significant benefit. For dysmenorrhea, again, there was no significant benefit. And for dyspareunia also, there was no significant benefit. So this is a practical plate for an Indian diet. So if you tell them for the breakfast, vegetable dosa, sambar, oats, nuts and fruit, lunch, brown, red rice or millet. Red rice has got a low glycemic index as well. And dal for 2 vegetables, curds if she tolerates, fish and egg if desired. Snacks again, fruit, handful of nuts, seeds rather than packaged snacks. Dinner, chapati, millet or vegetable, pulse and protein. So local affordable food that can achieve the same pattern, no need for expensive superfoods. So this is again a pregnant, like we give in pregnancy plate, you can give this endometriosis plate to a woman, you can advise them. So 4-step dietary counseling. First, you have to ask about the pain, phenotype, any bowel symptoms, what is the current diet or restrictions. Improve by whole foods, fiber gradually, healthy fats, and adequate protein. And you have to personalize one suspected trigger at a time, short structured trial. So review about the pain, bloating, bowel discomfort, or any adherence or nutritional adequacy. So myth versus what is the evidence says. So gluten free for everyone. No. Individualized and evidence is sufficient for universal elimination. Supplements are natural, so they work. No. 2025 placebo controlled meta analysis found no significant pain benefit overall. Diet can cure endometriosis? No. It is supportive but not curative. Food has no role at all. Also, no. Healthy eating supports overall health and may help even selected symptoms. So, what are the take home messages? First is think dietary pattern. Nothing is a miracle food. Whole foods, fiber, omega 3 rich foods, and healthy fats are reasonable foundations. Identify individual triggers. Do not impose blanket gluten or dietary restriction. Food first is preferable to routine supplement use for endometriosis pain, and recent randomized evidence remains limited. Counsel with humility and avoid over promising. That is very important. So, nutrition works best as one component of multimodal endometriosis pain care. So, there are other pain alternative pathways also. There are so many alternative treatments for endometriosis like acupressure, acupuncture, yoga, meditation. So, along with that, this nutrition also is added. So, endo supportive plan is one is nutrient intake. You should see that she takes adequate nutrients. Avoid this one sugars and the bakery products and other things. Avoid inflammatories and support gut microbial health. So microbiomes are emerging, and that's why we should always support microbiomes. Okay, so you have to always look at these points. So these are my references, and I'm very much thankful to all the people who spoke before me. It was a very excellent interactions with them. I thank the TNFOG President Dr. Amla Devi also, and my special thanks to Dr. Ramani again. Thank you very much.
All from fasting, right?
Yes.
And I thank Harshini. My special thanks to Harshini. Thank you very much.
Thank you, ma'am. Thank you for the one.
And Dr. Nivedita also. Niveda. Acha, it is Niveda.
Yes, ma'am. Thank you, ma'am. Thank you so much, ma'am.
Yes, thank you.
Thank you for that insightful and a very highly practical presentation, ma'am. You have clearly explained the supportive role of this dietary modification in reducing the inflammation as well as helping us manage this endometriosis associated pain, ma'am. Harshni, shall we move on to the next session, the quiz thing?
Yes, please. Thank you so much, ma'am, for.
Thank you very much.
Thank you,
madam. Thank you, everyone.
Thank you, all the speakers, for today's knowledgeable session. It was really so useful for us. And can we go to the quiz session?
Yes, ma'am. Jignesh, please proceed for the quiz.
So, we'll go to the quiz for a woman with endometriosis associated pain who's not currently trying to conceive. An appropriate first line hormonal treatment is A. GnRH agonist alone for 12 months. B. Combined hormonal contraceptive or progestogen. C. Aromatase inhibitor monotherapy. D. Danazol as first line treatment. Your last 5 seconds. The answer is combined hormonal contraceptives or progestogen. The next question. Which progestogen is commonly used specifically for long-term control of endometriosis-associated pain? A. Dynagist. B. Norethistron only during menstruation. C. Levonorgestrel emergency contraception. D. Dydrogestrone only after ovulation. Last 5 seconds. The answer is A. Dynagist. The principal reason for prescribing add-back therapy with prolonged GnRH agonist treatment is to A. Stimulate follicular development, B. Prevent recurrence completely, C. Reduce hypoestrogenic symptoms and bone mineral loss, D. Increase endometrial proliferation. C. Last 5 seconds. The answer is C. Reduce hypoestrogenic symptoms and bone mineral loss. Which of the following is an oral GnRH antagonist used in the medical management of endometriosis associated pain? A. Elagolix, B. Cabergoline, C. Clomiphene citrate, D. Ulipristal acetate. Elagolix. Ma'am, actually, there are people actually in the not in the speakers thing, ma'am. So they are actually answering. Last 5 seconds. A. Elagolix. Next question. Which of hormonal suppression in a women with endometriosis who's actively trying for spontaneous conception is generally A. Recommended to improve fertility, B. Recommended for at least 6 months before attempting conception, C. Not recommended solely improving pregnancy rates, D. Mandatory before ovulation induction. D. Last 5 seconds. So C, not recommended solely for improving the pregnancy rates. We don't give hormonal suppression. Which cells are increasingly implicated in the initiation and recurrence of endometriotic lesions? A, endometrial stem or progenitor cells. B, mature erythrocytes. C, hepatocytes. D, pancreatic B cells. A, endometrial cells, progenitor cells. Ma'am, don't prompt the answers because there are other people who are watching in the not in the speakers link, ma'am. So they are answering the questions, and the last few people and the first 3 will be selected. So the answer is A, endometrial stem and progenitor cells. Next question. One proposed mechanism by which endometrial stem or progenitor cells reach ectopic pelvic location is A, retrograde menstruation, B, biliary circulation, C, CSF migration, D, lymphatic obstruction alone. Retrograde menstruation. Last 5 seconds. The answer is A, retrograde menstruation. Apart from the endometrial stem or progenitor cell, which extrauterine source may contribute to regeneration of endometrial like bone marrow derived cells? A, bone marrow derived stem cells. B, corneal epithelial cells. C, mature neurons. D, thyroid follicular cells. The answer is bone marrow derived stem cells. Next question. Which of cells may help explain existence and recurrence of erotic lesion. If renewal and the absence of proliferation, C, inability to respond to hormones, D, and senescence. The answer is self-renewal and differentiation. Next question. What is the current clinical status of stem cell based treatment for endometriosis? A. Established first line therapy. B. Recommended routinely after recurrence. C. Experimental with research focused mainly on disease mechanism and future therapeutic targets. D. Recommended as an alternative to hormonal therapy. Experimental with research focused mainly on disease mechanism and future therapeutic targets. Next question. Which dietary component has acids? A. Omega-3 fatty acids. B. Trans fats. C. Refined sugars. D. Saturated fats. Last 5 seconds. A. Omega-3 fatty acids. Next question. Which dietary pattern is most reasonable to recommend as an adjunct for women with endometriosis associated pain? A. Predominantly ultra processed foods. B. Diet rich in vegetables, fruits, whole grains, and unsaturated fats. C. Zero carbohydrate diet for all women. D. High trans fat diet. The answer is B. Diet rich in vegetables, fruits, and unsaturated fats. Next question. Regarding a gluten-free diet in women with endometriosis, which statement is most accurate? It should be routinely prescribed to every patient. It cures endometriosis. Current evidence is insufficient to recommend universal gluten restriction. D. It is superior to hormonal treatment for pain. The last few seconds, and the answer is current evidence is insufficient to recommend universal gluten restriction. Which statement regarding dietary management of endometriosis is most accurate? Dietary therapy can eradicate endometriotic lesions. Diet should replace conventional medical treatment. Dietary interventions may be considered adjunctive, but evidence for specific diets remains limited. All women should avoid dairy products. The answer is dietary interventions may be considered adjunctive, but evidence for specific diets remains limited. Next question. A patient with endometriosis and significant bloating, IBS type gastrointestinal symptoms, ask about a low food map diet. The most appropriate advice is every endometriosis patient should follow it lifelong. It may improve gastrointestinal symptoms in selected patients, but should ideally be individualized. C. It directly eliminates endometriotic lesions. D. It is contraindicated in endometriosis. It may improve gastrointestinal symptoms in selected patients, but should ideally be individualized. The next question. In deep infiltrating endometriosis involving the bowel, the primary objective of surgery should be to A. Remove all visible lesions irrespective of organ involvement, achieve complete excision while preserving organ function, C. Perform hysterectomy in all patients, D. Avoid surgery because recurrence is inevitable. Last 5 seconds. B. Achieve complete excision while preserving the organ function. Next question. Which of the following is most important before undertaking surgery for severe endometriosis? A. Serum CA-125 alone. B. Assessment of disease extent and involvement of adjacent organs. C. Diagnostic laparoscopy in every patient. D. Starting antibiotics routinely. Last 5 seconds. B. Assessment of disease extent and involvement of the adjacent organs. Next question. During endometriosis surgery, uterolysis is particularly indicated when there is a superficial peritoneal disease only, the ureter is involved or at risk from fibrosis or adhesions, there is an isolated ovarian endometrioma, the patient has dysmenorrhea without imaging abnormalities. Last 5 seconds. The ureter is involved or at risk from fibrosis or adhesions. What is the preferred surgical principle when treating an ovarian endometrioma in a woman wishing to preserve her fertility? A. Remove the entire ovary. Maximize excision while minimizing damage to healthy ovarian tissue. C. Always perform bilateral oophorectomy. D. Drain the cyst without addressing the cyst wall. Last 5 seconds. Maximize excision while minimizing damage to the healthy ovarian tissue. And the last question, which statement regarding the recurrence after endometriosis surgery is most appropriate? A. Complete excision guarantees no recurrence. B. Recurrence is impossible after hysterectomy. C. Recurrence can occur and postoperative hormonal suppression may be considered when pregnancy is not immediately desired. D. Recurrence occurs only after laparoscopic surgery. The last 5 seconds. The answer is C. Recurrence can occur and postoperative hormonal suppression may be considered when pregnancy is not immediately desired. So, Dr. Vandana Gupta, she has got 18 correct answers. Then Dr. T. Janani, she's got 16 correct answers. And Dr. Harini, she's got 15 correct answers. Congratulations. And Dr. Kantipuli Sujana, Dr. Veronica Tunga, they have also got correct answers. Thank you so much for today's session.
Can we end the session? I think, yeah, Harshini ma'am, can we end the session?
Yes, yes.
Okay, ma'am. Thank you.
Yes, thank you.